We're here with Dr. Nick from Nuance, and of course I'm not going to slaughter your last name, so Dr. Nick works really well. So I just want to talk about, we're here at AHIMA 2012, I want to talk about some of the burning issues here in health IT. And the first one I wanted to hear your thoughts on is this whole upcoding debacle, right? And the government trying to slap down clinicians and hospitals that are upcoding, supposedly insinuating that it's fraudulent. What's your thoughts on that?
Well, it's obviously a hot topic at the show. There's been a lot of discussion about it. There was a number of articles and different position papers. And, really from the perspective of the care that's being delivered, the question I would pose is, have physicians been delivering less care because we know that they don't code to the level of the care that they deliver? So this whole issue of upcoding is really more about physicians now being able to correctly and accurately document the care that they were giving. So they were always focusing on the patient and delivering the best possible care. But because of the rules, the complexity, and some of the challenges, they face difficulties in terms of getting appropriately reimbursed. And what we're seeing is the impact of tools that are helping them achieve that. Now, other people have mentioned the concept of, was the rates made higher because they weren't getting paid? I think there's maybe been a number of compensation mechanisms, and some of that will level out. But the reality is that this isn't fraudulent activity. This is now just better clinical documentation that's occurring, and appropriate reimbursement for care that was delivered and at rates that were set by the government and the insurance market. So I don't see it quite in the same perspective.
Yeah, I mean, the interesting challenge, I think, is that certainly there is fraudulent activity from some doctors who do upcode trying to get reimbursement that they don't deserve.
Yep.
But I think that's a minority. So my fear is the government will come out and say, oh, here's a couple case examples that are really terrible and people doing really fraudulent things, and that the rest of doctors, which is the majority, are going to be lumped in with that minority of people.
I would agree. I mean, I think that's, from the perspective of a clinician, there's nothing more frustrating, I think, to the clinical community to see somebody that does that, because inherently I think we all start out with an intention to do good, to deliver the best possible care. And you're right, there's a very small subset, and if we all get tarred with that brush, it damages everybody, and it diminishes. If the process is designed to deal with that small minority, I think we're focusing on the wrong thing. We want to optimize the care that's given to allow clinicians to deliver it and capture the information appropriately. In part, I would suggest that maybe they won't feel the need to upcode because then they're getting paid. And I'm not advocating that the upcoding is an appropriate response or even the right thing to do, but that's my view.
Yeah, I mean, the doctors coming to my center are quite honestly angry that they're somehow being insinuated that they would be doing fraudulent activity. So it's interesting. So how about meaningful use stage 2? We finally have the rule and the details. What are your thoughts on that? What stood out to you?
I think there were obviously a number of components to that. We saw an extension of all of the components in Meaningful Use Part 2. From my perspective, one of the most interesting aspects to this was the focus on interoperability. I think there's been a lot of controversy centered on this patient engagement, and oh my gosh, we're being measured on how well the patients get engaged, but I don't control that. And I understand some of the resistance, but I think there's some very compelling reasons that that's a good thing.
Sure.
But the interoperability is sort of foundational to all of this, that says if I can share this information effectively and in a form that's useful, not just as blobs of text or these feeds that really have no structural value, I can change the way that we practice medicine. Now I'm not going to repeat a lab test. I'm not going to deliver or ask for another imaging study because I've got all of that information. That, to me, I think is one of the most exciting. It's a little bit of a whip with some carrots involved to say, start sharing this data. It needs to be shared for more effective delivery of care.
Yeah, I'm always torn because, we understand that there's value in sharing the data, but in this U.S. economic environment, you know, like, if I'm a hospital administrator thinking about interoperability and now I don't get a charge for that test, that was a lot of money for me. You know, like, I mean, I don't want to say that
maybe
all
upcoding.
economic, but I guess it could be. But, you know, I mean, yeah, there's going to be a lot of administrators that aren't going to say this publicly, that's going to hit their bottom line. They're going to miss out on a lot of tests if interoperability becomes a reality.
You know, and that's been part of the resistance and part of the reason that we've had such a challenge moving down that, because essentially you have businesses that are focused on business decisions. But this isn't about, I mean, yes, they have to run a business, but you know, as in all cases, I think they're going to have to adapt appropriately. At the end of the day, was it better to give the patient one X-ray or two for the same result? Well, I don't think anybody would dispute one was better.
It's easily clear.
Yeah. So that was, you know, and I understand that, you know, there's a revenue component to that that's going to impact people, but at the end of the day, that will free up resources to allow them to deliver other care to other people and do it at a more cost-effective rate. My underlying view.
And do you think Meaningful Use Stage 2 is going to cut through some of the EHR vendors, since there's a few of them out there?
Cut through meaning?
Are they going to, you know, are some of them not going to be able to meet the standard, or, you know, and we're going to see a lot of consolidation or companies going under EHR?
I don't know that Meaningful Use Part 2 will necessarily, you know, close down EHR vendors, although obviously, you know, the regulatory requirements may be too far of a stretch for some of the smaller. You know, you shared with us earlier somebody that you came across that was writing an EHR tool. You know, you question whether a single individual can meet those requirements. So there's obviously, you know, it does raise the bar a little bit. I think, irrespective of meaningful use, we will see some consolidation, if indeed that's possible. You know, given very disparate technologies, you know, we've not seen a lot of it, but there's been some.
If we only had a standard for true interoperability of EHR data, so that if you left the EHR, you could go to another one, right? Then the consolidation would happen much quicker.
Well, but to your point of, you know, the revenue impact, that's also a revenue impact to those, and part of the reason that the EHRs don't want to share the information is that, you know, it helps keep their customers. And, you know, again, same principle applies. The most interesting organizational chart I ever saw was the one that had the patient as the top of the chart and everybody reporting to the patient. And it's, you know, it sounds a little bit crass, but at the end of the day, that should be the guiding star. And if the guiding star says sharing that data effectively is best for the patient, then that's the right thing to do, and we should find ways to make our businesses work around that.
And I think that's key, is that there's still revenue opportunity. It's not like they aren't going to be seen.
Agreed.
It's, you know, the patient's still going to need services.
Right.
So how about the buzzword ACO? You know, what do you see happening with that? Are we seeing some traction? Are we seeing some light at the end of the tunnel, or are we still enjoying the unicorn?
Well, I remain convinced that the ACO concept will emerge as a component to our healthcare future. I think it, you know, it changes the way that we pay. And, you know, if you look at a lot of the resistance points to, you know, healthcare reform, many of them are centered on the fact that, you know, the principle of healthcare here is, you know, you get paid to do things, not to make people better. ACO is trying to change that. As far as the timing of it, I think we've got a number of other priorities that have been loaded on. You know, and I'll pick ICD-10 and Meaningful Use Part 2 as, you know, just two amongst a slew of other things that people have to focus on that will probably push out that implementation. But if you listen to many of the leaders, you know, many of the EHR vendors, you know, many of the healthcare delivery systems, I think most of them accept that as their future reality and are trying to position themselves to be able to cater for that. And to me, the key to success and the key to getting to that point for anybody is to have underlying data. You've got to be able to use, you know, without data you can't make decisions. And right now we're in an ocean, but we don't have access to the discrete data. And the focus today is making that information readily available to help towards that ACO concept of delivering and producing better care.
Excellent. Thanks for your time.
All right. Thanks, John. Always a pleasure.